Hi, and welcome to your lecture on urinary incontinence. Be sure that you read your corresponding chapters in your textbook for in-depth information about urinary incontinence. This brief overview presentation aims only to hit the highlights of the information that is encompassed in your chapters in your textbooks. Chapter 43 goes over common urinary complaints, and those will not be encompassed in any of the PowerPoint presentations. So urinary incontinence, it's common in women and in older men who have enlarged prostates because of its impact on the urethra, correct? It is not considered a normal symptom of aging. Please see page 630 for details and more in-depth information about the causes, approaches to assessment, and the management of the different types of incontinence. And know that it is not uncommon that your patients may have demonstrate symptoms associated with mixed types of incontinence. Please know that in chapter 43, there's a table on page 624 that looks at urinalysis findings and goes into some information about pertinent abnormal findings that you may find on those types of testing. So when you're looking at your subjective data and attempting to collect that, you're going to ask your patient lots of information about frequency, urgency, pain associated with. Is there any leakage with any stressors like a cough or intense laughter? Are they waking up numerous times in the night to void? Do they see blood in their urine? What about the ability to start and stop their stream? Do they have decreased volume in their stream, as some men notice with enlarged prostates? Do they feel like they can completely empty their bladder? And do they have a problem with constipation? When you're doing your objective data collection, of course, you're going to do a neurological evaluation, an abdominal assessment, a pelvic if it's a female patient, a rectal probably for both patients, but certainly for your male patients because you're looking to see if there's any presence of benign prostatic hypertrophy or prostatic hypertrophy that would need to be determined if it was benign or not, correct? And then you're going to do a cardiac assessment. And so why would we say cardiac? Well, we would say cardiac because your patients with CHF, the literature tells us that about 50% of those patients experience incontinence. Now, is that related to their diuretic therapy? Possibly, right? So then that takes us to our next part of this slide. What are the potential differential diagnoses that you might want to consider? Well, certainly if your patient is on IV hydration, they may not have the ability to control the volume of urine that's going to be produced secondary to the hydration. But then your patients with Parkinson's or other types of dementias, or patients with strokes who have neurologic deficits, or patients with MS or diabetes, patients who have prostate enlargement or cystoceles or pelvic strictures, pelvic floor muscle challenges, bladder outlet sphincter problems, or anything that changes or causes an intra-abdominal pressure or the presence of stones in the bladder. So all of those could be your potential diagnoses, and it's your responsibility to systematically approach the subjective and objective data collection for your patient presenting with urinary incontinence to be able to determine what the most likely diagnosis is. And so part of your workup is going to include looking at the urinalysis, maybe doing a culture and a sensitivity depending on the characteristics of the urine upon your inspection of the urine that the patient has voided in your office. You can do a comprehensive metabolic panel to tell you some things about renal function. Bladder scans will give you information about whether or not the patient is able to completely empty their bladder after they void. You can do a post-void residual catheterization. Transrectal or pelvic ultrasound can be utilized to get a better evaluation and examination of the bladder itself. And then urodynamic testing can be done. Usually that is done in a urologist's office. But there are some primary care provider practices that will do urodynamic testing. And that's where they have the patient, they measure the speed or the rate, or the velocity is a better word, of the patient's voiding stream. You know, and then management. Well, of course, management is going to relate back to whatever it is that you've determined is the etiology for this urinary incontinence. So if it's diuretic therapy, why is your patient on diuretic therapy, and can you adjust that pharmacologic management to see if you can't relieve some of that? Bladder retraining programs, particularly after somebody's had an indwelling catheter, are of tremendous value. For stress incontinence, there are certainly medication, pharmacologic management that you can use, both oral and injectables. Kegel exercises are of value. There are biofeedback approaches, electrical stimulation approaches, the utilization of vaginal cones or pessaries. And then for urgent incontinence, also Kegels and biofeedback, managing fluid intake. If there's the presence of any infections, then antibiotic therapy. This medication, pharmacologic agents could be utilized, and in both of these cases, then surgical treatment would certainly be the last option that you would want. So for overactive bladder, you have oral and injectable medications. For overflow incontinence, that's where your toilet training, your bladder training, Creed's maneuver. If there are medications that are causing this overflow problem, you want to evaluate the need to continue those medications or make adjustments. And then certainly utilization of urinary catheterization processes and procedures to help relieve the volume of urine in the bladder. Functional approaches include, as we said previously, Kegel exercises, biofeedback, any offending medications, certainly managing fluids, whether that's from IV perspective or oral fluids, putting a patient on scheduled bowel and bladder programs, bladder retraining, utilization of catheters at a minimum, hopefully, and then looking at any potential underlying disorders and making corrections or treatment plans to address those. And on page 635 in your text is some instruction that you can provide for patients on Kegel exercises. So how often do you want to see these people? Well, you want to see these people in your practice initially, once you've worked them up and come up with your working diagnosis, probably biweekly. Have them check back in every 3 months. Now, a lot of, we said older males, right, and then females are subject to urinary incontinence. Certainly some of the medications, like the anticholinergic agents that you might utilize with your patients, they're going to potentially cause some other problems for your patients, right, and particularly your elderly patients. So you're going to want to bring those patients back in on a periodic basis, maybe about every 3 months, so that you can make sure that you're not causing any particular problems to the physiology. So for like stress incontinence, they're using alpha blockers. Well, alpha blockers are also used for the management of blood pressure. So you want to make sure you monitor that you're not having a negative impact on the patient's blood pressure over time. For urge incontinence is where they use the anticholinergic agents. If you're, and that can cause the dry mouth and the loss of moisture in the fecal material, and so you can complicate some other problems, particularly if the patient is constipated already. If you have a female patient, you're going to want to do some pelvic evaluation, and if you have a male patient with incontinence, you're going to want to do rectal exams to continue to monitor the status of the prostate. You know, referral to urology if some more higher levels of assessment are necessary or testing are necessary, like urine dynamic testing. Perhaps to the gynecologist if the patient has a cystocele that might be able to be addressed with a procedure that a gynecologist could utilize for them. And then your physical therapists and some urogynecologists are utilizing the biofeedback methodologies and the exercise methodologies, etc. And so that's just a brief overview of urinary incontinence. So as you can see from this slide, the patient with urinary incontinence really is a multifaceted approach to care. Certainly, you would want to look at how is this impacting your patient? A lot of patients with urinary incontinence don't like to go out, or if they go out, they don't stay out for long periods of time because they don't trust their Depends or their panty liners or whatever to keep them dry if they have some leakage issues. Evaluate their dietary intake with them. Certainly, if they have high caffeine intake, they would want to reduce that. And if they have constipation problems, then you might want to suggest Bran. We talked about some of the mind-body techniques, which were the biofeedback, the Kegels exercises, the relaxation exercises, utilization of transcutaneous electrical nerve stimulation. And in the world of energy medicine, you might want to check for spiritual connectedness. If you're going to put them on bowel and bladder training, you're going to want to know what kind of level of support that they have for that. Are they going to have the mobility capacity to be able to engage in those programs, etc.? What are they utilizing now, and what can they maximize as far as their self-care strategies go, as far as pads that they use, or pads for the beds, or can they do their toileting programs, their bowel and bladder training? How can they adjust their liquid intakes, etc.? And do they have the capacity to health literacy to understand when you instruct them on Kegels exercises? Will they be able to carry that through, etc.? Be non-judgmental, of course, advocate for your patient. Those kind of go without saying. From a physiologic, there can be structural approaches like cones or pessaries, etc., intermittent cathing for overflow incontinence, and the pessary would help with pelvic organ support. Pharmacologic agents include the tricyclic antidepressants, the stress incontinence alpha adrenergic agents, and for urge incontinence, the anticholinergic agents. But keep in mind, all of those come with potential other problems they can create for your patients. And certainly the last option would be your surgical interventions. They would stabilize the detrusor muscles, and then there might be sling or suspension procedures. And here's your reference, and thank you for your attention for this overview of urinary incontinence.